Good afternoon, Dr. Chapman. How are you?
Good afternoon. Glad to be
Good.
with you.
Yeah, I'm looking forward to our conversation. I know you have a tremendous amount of information for the community. Before we get started, though, can you briefly introduce yourself and tell people what you do?
So I'm Dr. Edwin Chapman. I've been practicing internal medicine in Washington for over 40 years. And for the past 20 years, I've been involved in addiction medicine, primarily opioid treatment. Uh, First, initially in a methadone clinic for 12 years. And then about 15 years ago, I got so intrigued by the population that I started with a pilot demonstration project with the DC Superior Court using an office-based medication called buprenorphine. And ever since that, I've been working with a large population of patients addicted to heroin and now fentanyl.
Yeah, and it's so important to have people like you. As you know, the treatment of substance abuse and addiction is somewhat stigmatized even in the provider community.
Absolutely.
Really appreciate your work. I think it's important to help people understand though what we're talking about.
And it could be a legal substance or an illegal substance. Legal substances that one can get addicted to are things like tobacco products, alcohol, and of course, illicit substances like heroin, cocaine, and drugs along that line. So it can be either uh, uh, really uh, uh, legal substances or illegal substances, but it becomes a problematic when one has difficulty stopping the use of that substance, whatever it is. And that means that you're having either using more to get the same effect, or when you try to stop or cut back, you find that you have withdrawal symptoms, sweating, uh, uh, stomach cramps, diarrhea. So it can be either a legal substance or an illegal substance that causes one to get addicted. Some people, of course, even get addicted to caffeine, coffee, which is probably the most common thing, a substance around other than alcohol and tobacco.
But it's interesting to me. I mean, that's a good point. People can be addicted to caffeine. People can be addicted to nicotine. People can be addicted to alcohol. But for some reason, those aren't as stigmatized as drugs. Why do you think that is?
Well, years ago, it was found to be profitable, and uh, and an economic base was built on that, and then taxation followed that. So all three of those substances are taxable items that the government makes money off
You mean
of.
the alcohol, tobacco, and caffeine, you mean?
Right, right.
Got you.
All are
Mhm.
all are taxable items, and one might look at marijuana in the same respect now. You know that it's been legalized in a number of places, and it's a taxable item. That does not necessarily mean that it's good for you or good for your body. But again, uh, there are various reasons why uh, you have so-called legal substances. In fact, I can't think of anything in a positive way that any of those substances are good for your body in the long run.
Yeah, so there's a profound hypocrisy in that, right? The distinction between those three and then some of the other illicit substances you were talking about, PCP, heroin. How do you think we move beyond stigmatizing some kinds of substances and not others?
That's a very difficult question. Uh, One of the things that we are trying to do now is really because we know that these substances do damage to the body, regardless of what they are. That we're trying to broaden the base of understanding in the community. So we're trying to take the message out of the doctor's office into the community, and actually forming alliances with particularly the faith community for one, but also our beauty shops, barber shops, places where people feel comfortable are generally the best places to start that conversation. So we have to, Lisa, that healthcare is siloed for the most part.
Yeah.
Yeah, mental health, substance abuse, and general medical services, and they all sit in their little pockets. And under the Affordable Care Act, under what is called the Accountable Health Community, we're trying to merge the three so that you can enter the system either from your primary care provider, who would be more cognizant of picking up on mental health and substance abuse problems, or your substance abuse provider might determine that you have a mental health problem and really integrate that into the services. So we're really trying to close those gaps in care because we know that they're immense, and there are actually laws on the books really trying to force that, but sometimes you get a bureaucratic pushback from the insurance companies in terms of payment and resources. Particularly in the African American community, know that we're only 5% of the physician population, 4% of psychologists, and 2% of psychiatrists. So we really have a personnel gap, and that means that we have to work very efficiently because now we're being overwhelmed with so much stress in the community.
Yeah, and I think that's a really good point. And it highlights the need for us to find other helpers in the community to address this problem or provide support for people with mental health disorders and addiction. Do you have some thoughts about how we could expand the helper pool?
So I'm glad you mentioned that. And we're now talking about peer navigators or peer counselors, people who have had lived experience, who are in recovery or who have recovered, so to speak, that they, in many instances, are the best persons to really help one walk through that maze. And then patients often feel more comfortable talking to somebody who is really talking to them rather than talking at them, so to speak. And of course, in the healthcare arena, we have a tendency to take an authoritative approach.
I call it paternalism.
Paternalism, and patients reject that. There's a fear associated with that. So we're really trying to change our approach so that we're really working with patients rather than dictating to them. And we're trying to get that same message across to the faith community. There are a number of papers out and studies out now really trying to integrate the faith community because, again, as you mentioned earlier, just as the medical community has its own ingrained stigma, so does the faith community in many instances have a preconception of this person is possessed or there's something wrong with them rather than the fact that they need help.
And that's ironic because that's the place where you would expect the least amount of judgment, despite the pews being filled with people who may be smokers or people who are overeaters, people with their own challenges. So it's really interesting that this is not a place you can uniformly go to for support. We need to work on that.
And I'm glad you mentioned that because there are other addictions. There's shopping addictions,
Yes.
addiction. Um, um, I often tell people, look, we're all addicted to something unless you're suicidal. There's something in life that you like that you
Hmm.
have to really put controls on so that you don't overdo it. And that's what makes us feel good. You know, we wake up in the morning. You might want a glass of orange juice or a couple of donuts. Uh, 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 that's what makes us feel good. But you also have to control it so that in moderation. But
Yeah.
that's really the balance of our internal dopamine system.
Hmm. You know, during the pandemic, we're hearing a lot and seeing um, a lot of depression, social isolation, um, which might be compounding the substance abuse challenges. Are
Oh,
you seeing
absolutely.
any differences now during the pandemic? And can you talk about that?
No, you're absolutely on target. We're communal beings, meaning that generally we like being around other people just by nature. That's what
Hmm.
you mentioned earlier about us going to work in spite of the pandemic. But we want to connect with people. And when you're forced to uh, really stay in isolation, uh, that becomes very dangerous for people who suffer from anxiety or depression, especially if they don't have a, person, a trusted person that they can communicate with on a regular basis. So staying connected is extremely important. The upside of that is even in healthcare, we've now suddenly developed an affinity for so-called telehealth almost overnight.
Hmm.
When before we had such difficulty getting the bureaucracy sometimes to understand the efficacy of
You're muted, Dr. Chapman.
okay,
Oh yeah, I can hear you now.
okay.
Sorry, you were
So
on a roll too.
so so we, telehealth uh, has been the positive upside of this whole pandemic because suddenly we found a way or been forced to find a way to connect with our patients and connect with others in order to really stay open in many instances because services even in the healthcare arena uh, in many instances have been cut back to or reduced to so-called essential services. With mental health needs and substance abuse treatment needs never go away. So a lot of clinics that treat mental health and substance abuse have had difficulty because their patients can no longer come in for groups or come in for face-to-face counseling. So we're now using telehealth or video connections using Zoom and other mechanisms, iPhone, to really connect with patients. And the government has been good at really reducing those barriers. Now, one of the problems in our community in particular is our patients don't always have access to internet or to computers or to the
Really?
minutes on an iPhone. So they're very, so that is something that we're really uh, trying to bridge the gap on is the technology gap.
So, how
And
prevalent is that though? Because I've been practicing telemedicine during the pandemic, and most people have a smartphone. They either don't know how to use it or they don't feel comfortable turning on video, either because they say their house isn't ready for video or they're not like physically ready for video. So, how much are you seeing people just not having the technology?
so again, my patient population is about 250 heroin addicts, And
Mm-hmm.
that subpopulation many times is homeless, or they are living with relatives or friends that, that don't have access to the internet, and they have financial barriers as well. So it is significant as you have to look at the socioeconomic of the patients. I
Yeah.
always tell people that if you're looking at a population, our population are not generally senior citizens sitting at home by the telephone. Our patients are often the people that you see out on the street and really disconnected from a lot of things that we take for granted.
So if they don't have smartphones and they don't live in a place with internet access, how do you find them or how do you treat them?
Well, because we're using medication assisted treatment, uh, that becomes really a positive in that they have a, a very restricted amount of medication. We might give them a week supply or two
Mm.
week supply or a month supply. So, and an appointment to come back. And so that patient population has been very compliant in terms of follow up. And we use that as a mechanism to really develop a patient centered model so that when they come in the office, we do what we call reverse telemedicine. So we have rooms in the office where we can put the patient and then let them connect to social services in a
Oh,
reverse
nice.
manner. And
That's
so if they
great.
need to talk to the social worker about housing, rather than using their time or their cell phone or the fact that they don't have a computer, they use a computer in our office and we connect them to those care coordination services.
Yeah. Okay. So I want to shift and talk a little bit more about some practical aspects of addiction. When I think people feel somewhat intimidated when it comes to approaching people who have addictions. And I know I felt this sometimes when I'm out in the community and I've managed to get my hands on Narcan just in case. But most people don't have Narcan. So if people in the community want to understand what to do, how to intervene, how to help someone who may be going through an episode or in the midst of an addiction crisis, what should they be looking for? Are there things they can see that will identify what's happening with the person, and then what should they do to help?
So addiction and mental illness are what I call head diseases, and they're very difficult. People don't come out and tell you that I'm mentally ill
Hmm.
or I'm addicted to this. They always say or deny. So denial is don't even know I am lying, and that's the patient's perspective is that they don't see themselves as having a problem, and therefore they have a tendency to reject those offers when you're trying to help. So it becomes very difficult. That first step, getting a patient into treatment, is requires having a trusted person, a trusted friend, a trusted relative, someone that can sit down with you and really explain to that person what they've they've been doing that seems out of the ordinary. And that's why we're trying to really broaden that base to the faith community, to barbershops, to beauty parlors, uh, uh, and and there's a stigma associated with even talking about it in the African American community.
Hmm.
It's for so many years been considered a sign of weakness, and so even if we feel that we need help, we won't ask for help because uh, people don't walk around and say that they felt depressed. Uh, so we're now using uh, screening tests in the primary care doctor's office, uh, more so on a routine basis, or when patients go to the emergency room. And this is something that we've not done routinely in the past because patients come in to the emergency room or the doctor's office, and we have a tendency not to address those types of problems. We address physical problems, not understanding that many times there's a mental health problem associated with that physical problem.
Yeah. So should we be thinking about substance use disorders and mental illnesses together, or is there a distinction between them?
They are very closely related. We now know that if you take any chronic disease, whether it's high blood pressure, diabetes, congestive heart failure, the cost uh, without mental health or substance abuse uh, uh, is about 20. Well, I'll say it another way. The cost goes up 4 times if you have both. So if you have both a mental health and substance abuse problem, the cost of treating high blood pressure, diabetes, and that makes sense. That if a person is depressed and they're, let's say, drinking alcohol to soothe their depression, then they're very likely not going to take their blood pressure medicine or their diabetes medicine. So it makes absolute sense. So we know that for instance, with opioid addiction, that 50% of the patients suffer from either anxiety or depression, and 90% have a diagnosable mental health, uh, uh, a DSM mental health problem. So there's a very close association. Now, the question is, what came first, the chicken or the egg? Uh,
Mm.
and that requires a lot of work, a lot of trust, a lot of conversation, and we're really now looking into what we call adverse childhood experiences and adverse community environments. Uh, we're in an atmosphere right now that's both politically stressful, economically stressful, and we're now seeing the impact, as you pointed out, of how that's related to an increase in alcohol use, an increase in overdoses, uh, because that type of so-called community toxic stress impacts everybody. When you wake up in the morning and you hear that there's a shooting down the street, or somebody was overdosed, or somebody died from COVID, all of those things really cumulatively impact the entire community, unless you're just totally uh, removed from the circumstances. But if you're involved, all of that becomes cumulative stress.
Yeah, it'd be hard to imagine anybody being completely uh, separated from these issues. You know, we talk about mental illness usually when it's profound depression or bipolar disorder, and we don't recognize that mental health is a spectrum, right? It's from being very sad, maybe you lost someone, all the way to something drastic like bipolar disorder. I think we need to talk about mental health and mental illness or mental wellness as a spectrum. But who do you think needs to be talking about this to help destigmatize it, to make it okay for people to seek help?
Well, I think the the uh, George Floyd incident almost overnight turned on a switch.
Mm.
And all of a sudden, we're able to talk about racism openly, without fear. We're able to talk about uh, how we feel. Um, uh, but the beauty, I think, is to see so many young people out in the community of all races, uh, all creeds, uh, really saying, uh, in effect, we're in this together. And I think that really opens up the conversation. When you see people who don't look like you, who suddenly recognize that this is a problem and openly talk about racism, then it makes it much easier for us to really express ourselves and talk about how we actually feel. So now we're really seeing people wind the clock back and understand that the past 401 years in the African American community is no different from what we're seeing at the Mexican border, so to speak. You see
Mm,
families torn apart. Uh, 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 that's no different from our families being torn apart 400 years ago. So you really have to have that common sense of empathy and understanding that, hey, that could be my family. Would I want that to happen to me? We see people losing their jobs. We see how quickly you lose your job, you also lose your health insurance. So I think Martin Luther King said it best that we're basically all in the same clothing, so to speak, and what happens to one impacts the other. We start to have that understanding of unity. You know, it's unfortunate that we've had to have this type of stress to bring us to this point, but I think it's really making us understand that everybody needs health insurance, everybody needs shelter, everybody needs income, everybody needs food. It grieves me to see these long food lines. I mean, it's
mm-hmm.
unimaginable. Uh, but yet, on the other end, you have good people out there working uh, 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 day in and day out to help others. And so I think this is really a time for us to really look at the positive side and what we can do to do our part. Somebody asked me the other day, um, well, why do you go in the office to see these patients? I said, well, think about the doctors who are in the ICU, who are in the emergency room, who have all of these PPE equipment and gowns. Uh, who's at more risk, me or them? So my job
Yeah.
is to keep my patients out of the emergency room so that we can reduce the pressure on those folks who are really at highest risk. And so we all have to do our part. I think that's the message.
That's such a great message. And the last question is about where people can find help. We talked about people being reluctant to seek help. And I think we need to offer resources that can maintain people's confidentiality. So, what's your advice for someone who knows they have a challenge with the mental health disorder or substance use disorder, and they're afraid to get help, but they need to get help? Where can people go? What do you suggest?
So again, all of us should be a conduit. There should be no wrong door, meaning that it could be your hairdresser, it could be your pastor, it could be your doctor. We want to create an atmosphere where people recognize someone close to them has a problem, and that it's very difficult. The closer you are to that person, but uh, you're also more likely to have success if it is a person that is trusted. And they may be angry initially, but generally they'll come back and say you were right. Uh, so we have to gingerly move people into treatment. And again, it has to be whoever is closest to that person at that particular time. And that's the kind of unified atmosphere we're trying to create. There should be no wrong door.
Yeah, that means we have a lot of work to do to make sure everyone's educated to know where these resources are. And what if I'm someone who decides I'm ready and in that moment not sure what to do? Is there a national resource or something you can point people to?
I think depending on the urgency, if it's uh, immediately after an attempted uh, non-accidental overdose, then I think that person should be taken directly to the emergency room. But if it's a conversation, then I think you can start with your primary care provider initially, or with the insurance company that you participate with. You can call them and ask for the direct connection to mental health services. And of course, most health departments have a behavioral health agency that can be contacted and directed. So I think, again, it varies depending on the location
Mhm.
and the insurance coverage, and geography has a lot to do with it. Also, whether you're in a rural area or an urban area, I think it's much easier if you're in an urban area to contact resources than in a rural area.
Okay, well, thank you so much, Dr. Chapman. I would love to follow up with you at some point. It sounds like we've made some headway, but we still have a ways to go. So we'll have to keep this conversation open.
And thank you so much.